Hi, ladies and gentlemen. Forgive my interrupting. It's great to see everybody meeting old friends and old colleagues here. And I know this room will fill up as the day goes on, but as we have several hundred people online, I did want to get us started on time. My name is John McLean. I am the Executive Director of the Asia Pacific Alliance for the Control of Influenza, and I'm really pleased to welcome you all to our first in-person event in 2 years. It is great to see everyone again. If you're a member, it is wonderful to be able to meet you in person. Most of you I've only met online. If you're not a member, either whether online watching us or in the room today, please consider joining APACI. We have memberships across 26 countries at this point, and we would very much welcome your presence in our group. You can go onto our website at apaci.asia and take a look, and we are updating the website soon. That is my next priority after this meeting. So please do reach out to me with any questions at admin@apaci.asia, and I would be happy to get back to you. On to the conference. Our conference theme is the collaborative responses to fresh challenges. Throughout today's program, we're going to explore topics around influenza, RSV, COVID, pandemic preparedness, vaccines across the lifespan, and mitigation and treatment for severe disease. We're very grateful. I'm personally very grateful to our distinguished speakers and session chairs for sharing their expertise today. And I'm very much looking forward to the presentation. A few housekeeping notes. If you could please make sure that your phones are on silent, particularly notifications. This event is being recorded, and the recording will be uploaded to the apaci.asia website in coming weeks. It'll be free for access, and please do take advantage of that. During the question and answer period, we will be moving around the room with wireless microphones. Please do ensure you speak into the microphones so that the online audience can hear you clearly. Even if you have a voice like mine that carries in a room like this, it does not carry very well into the ether unless we speak into the microphone directly. Online questions will be sent to the chair via SMS. If you have any issues on this, Mary Ann will be able to help you out directly. So for our chairs, if you have any questions how that'll be handled, please do speak to her before your session as chair. To help us stay on time, a bell will ring. I will ring a bell at 3 minutes, and again at 1 minute. I apologize for any irritation that may cause, but hand signals don't always get picked up in these circumstances. I'd also like to acknowledge today's session chairs. We have Kim Sampson with session 1. Professor John Tam will be our chair for session 2. Professor Paul Tambyah, session 3, and Professor Hui Lang Yen for session 4. And a huge thank you to our sponsors back of the room, Moderna and Seqirus in particular. Without you, this would not be occurring. And so please do take time to pop in and say hello. And we at APACI are incredibly grateful for the support and hope to be working with you closely moving forward in coming years. This event has also been funded in part by the IFPMA, the International Federation of Pharmaceutical Manufacturers Association, and we'd like to reach out to them. Hopefully Paula is listening, and thank them again for their ongoing support of APACI for many years. Finally, I'd like to thank our peer groups in the modern political environment. Working with peers internationally seems to be the most effective way of maintaining international linkages in health, even when the politics occasionally get in the way. With that in mind, I cannot thank enough ISERV, ESWI, from whom Colin Russell will be speaking to us today, MENA, CPMA, and the Global Influenza Initiative. And speaking of CPMA, I also did want to note, I hope to see some of you at the World Influenza Conference in a couple of days. It'll be this weekend in Chengdu. As soon as we're done here, we will be shifting to Chengdu. APACI is co-hosting that with the CPMA. And if you haven't registered, even if you can't make it, consider registering it online. It's going to be a great event. So with all that, let's get into what we're here for. Please join me in welcoming Professor Joseph Yu, Professor Joseph Wu from the Hong Kong University School of Public Health, who will present vaccine hesitancy in East and Southeast Asia. Thank you, Professor.
Good morning, everybody. Well, first, I would like to thank the organizer for giving me the opportunity to present to you today. So apologies for the slight change in title, because I want to make the talk more general, understanding that audience comes from all parts of the world instead of being too geographical specific. So title of my talk, Preparing for Vaccine Hesitancy in Future Pandemics, Building Trust in Peacetime and Nowcasting During Crises. I would like to start with a quote from Walt Orenstein, whom some of you might know. He was the former director of the US National Immunization Program, and I had the privilege to work with him at one of the committees called IVREC at WHO. So here's what he said in one of the articles that he wrote a number of years ago. Vaccines don't save lives. Vaccinations save lives. Which, what he means is that in order for vaccine to have impact, of course it's important to have safe and effective vaccines, but that's not sufficient. We have to make these vaccines available and accessible to the general public, and also the general public need to accept these vaccines in a timely manner. One of the painful lessons that we learned about timely acceptance of vaccine is what happened during COVID in Hong Kong here. So some of you might know Hong Kong was able to suppress the spread of COVID during the first 2 years, 2020 to 2021. But when Omicron started emerging and spreading, what used to work, the public health interventions that used to work against more ancestral strains were no longer sufficient to control the spread of Omicron. So as a result, Omicron started spreading widely in Hong Kong in January 2022. And at that point in time, more than 50% of those aged 60 or above remained unvaccinated. As a result, 96% of COVID deaths during the Omicron wave occurred in this age group. So for a week or two, Hong Kong had the highest COVID deaths around the world, which is, of course, in stark contrast to how we have been doing before Omicron started spreading in Hong Kong. The situation in terms of mortality, COVID mortality, is in stark contrast with New Zealand, which, similar to Hong Kong, was able to suppress the spread of COVID-19 during the first year or two. However, their vaccination coverage, especially among the high-risk groups, the older age groups, were much higher compared to Hong Kong. And as a result, although Omicron spread in New Zealand just like it did in Hong Kong, the case fatality rate was 10 to 100 times lower compared to what we had in Hong Kong. So this is, again, lessons learned, real-world examples, very recent examples of why timely acceptance, especially among the high-risk groups, is so important. Vaccine hesitancy is not a new problem. It became more pronounced and more observable during COVID-19. But the WHO recognized this as one of the top 10 threats to global health before COVID in 2019. So if you go to the WHO website, you can find this list, and on this list, vaccine hesitancy is one of the threats listed. Here's how WHO defines vaccine hesitancy. It refers to the reluctance or refusal to vaccinate despite the availability of vaccines. And vaccine hesitancy is a complex, dynamic continuum rather than a binary state of pro-vaccines versus anti-vaccines. So for example, some people indeed are very resistant to all kinds of vaccines, whereas others would take the recommendation from the officials, local health officials, and accept most of the vaccines. But many of us are in between. We accept some vaccines, but not others, depending on whether we think they are important for us, and of course, depending on whether we think that particular vaccine is safe and effective. It is also highly context-specific, depending on location, depending on history, depending on politics, religious beliefs, etc., etc. So as you can imagine, because the underlying drivers is very social-oriented, there's substantial heterogeneity across the world, and also, even if we talk about the same pathogen at the same place, vaccine hesitance can also change over time substantially. As mentioned earlier, vaccine hesitancy is not a new problem. It is basically as old as immunization itself. So over the past 200-300 years, there have been on and off substantial resistance to vaccination, even though when they are mandatory. But the scope and scale has escalated, especially with recent advances in digital technologies in the past couple of decades. And also, over time, some groups with specific agendas has learned that vaccine is a very, very polarizing topic, which can be easily weaponized to drive attention and traffic. One of the most well-known example was the Wakefield study about the fraudulent claim on the association between MMR vaccines, measles vaccines, and autism, which was published in the Lancet in the late 1990s, but was eventually retracted. But that didn't happen until 10 years after its first publication. And during that time period, a lot of things have happened, including this, the spread of vaccine hesitancy because of this study itself, but also the wider spread global of phenomena of people using vaccine hesitancy as a cue to promote their own agenda. These are some data to illustrate what I've mentioned earlier, the wide disparities and volatility of vaccine hesitancy. On the left is a report from Wellcome Trust funded study before COVID, illustrating that indeed there's a wide spread of vaccine confidence across different jurisdictions, even after stratifying by continent. For someone who is new to this topic, it might be a surprise to you to find that if you look at this figure, which I understand is too small for some of you to see, some of the jurisdictions with the lowest vaccine confidence are actually high-income countries, whereas some of the jurisdictions with the highest vaccine confidence tend to be low-middle-income countries. So that is sort of like puzzling if you are new to the topic. But if you look at data collected over the past 2 decades, the data suggests that this is not an anomaly. It is a fact. And indeed, during COVID-19, many studies have found that no matter at various geographical scale, from global to regional to national to local, there's vast heterogeneity in vaccine confidence, vaccine uptake, etc. So, for example, in the middle, the map of the United States showing the vast heterogeneities, geographical heterogeneities of vaccine confidence across the United States about COVID-19 vaccines in year 2021. And then the study to the right shows over time how people feel about COVID vaccines. Which prompt the development of a model to understand what are the underlying drivers. So the first model, the so-called 3C model, was first developed in 2012, and it has been improved over the years. Now we have the most current model is the 5C model, developed in 2018. So the first model emphasized the importance of confidence, complacency, and convenience. And over time, as the model was improved, there were some revisions. For example, instead of calling one of the drivers convenience, it was extended to constraints, which is not just logistical convenience, but also some other kind of social, for example, constraints. And also adding collective responsibilities in the 5C model. Collectively, these 5 Cs we were able to explain 20 to 40% of vaccine behavior globally, as shown by the study that first introduced this model in 2018. Because of time, I won't go into the details of what these 5 C's are. So I'm just going to flash through this quite quickly. The first is confidence, which is, I think, the most important and the most difficult to tackle. It refers to the trust in safety and effectiveness of vaccines, which is quite intuitive. But at the same time, it also refers to the public's trust in the healthcare system, the people who are promoting the vaccine, including the health officials and the scientists, and also the messenger who is telling them, who is giving them the vaccine information. Next is complacency. If people perceive that vaccine-related outcome is not severe, of course, they'll be less likely to take the vaccine. This is relatively easy to tackle compared to confidence, because oftentimes this has to do with lack of information or misinterpretation of information. As mentioned earlier, constraint is an important driver. It refers to exogenous barriers, for example, accessibility to the vaccine and affordability, but also psychological barriers. For example, if people, even if accurate information is provided to them through different means, maybe they don't have the numeracy or literacy to understand the risks and benefits of vaccination. Next is calculation. People, when making decisions, all of us, weigh risks and benefits, especially for something like a preventive measure such as vaccination. So there are groups who would, quote unquote, overthink, the risks and benefits. And if the risk is not immediate, this group tends to wait and see, and that also constitutes to vaccine hesitancy. And then finally, collective responsibility. We understand that, for example, childhood immunization, a lot of the vaccines are put into that program because of one of the main reasons is, of course, to directly protect the children, but at the same time to protect the community from transmission of disease. So this dimension is also important. Which leads us to the first pillar, trust. As mentioned just a while ago, confidence is the most difficult to tackle. Studies have found that there are effective interventions for the other 4 drivers, but there are not that many effective interventions to alleviate confidence issues. Studies have found that most trusted source for vaccine confidence, as you would expect, include doctors and primary care providers, nurses, pharmacists, etc., but also, again, unsurprisingly, family and close friends, who might not necessarily be the best, most knowledgeable person about vaccination, community and faith leaders, and also public health agencies and scientists. As mentioned earlier, vaccine hesitancy was recognized as one of the top 10 threats to global health. So WHO has been working on documentations on providing guidance and advice on how to manage this problem. So this document, Vaccine and Trust, you can find that on the WHO website, which was published before COVID-19. So you can read about the key factors there. These are some of the studies conducted during COVID to illustrate the importance of trust. For many communities, the messenger is the intervention. Oftentimes, vaccine hesitancy has less to do with the vaccines themselves, but more with the messenger, the message, how that message is communicated, etc. So, for example, the study on the left was conducted in 23 countries, which found that people's sentiments about vaccines is often not constrained to the specific vaccine that is being talked about. So, for example, this study reported that because of COVID experience, 60% of people reported more likely to accept other vaccines afterwards, whereas 20% reported that they would be less likely to take other immunization after COVID, which emphasized that vaccine hesitancy and trust challenges remain for public health practitioners and require very, very context-specific solutions. One-size-fits-all is not going to work because people have different concerns different reasons for resisting or being hesitant about vaccines. Similar findings from the other studies I'm showing here. The perspective in the study at the middle shows that the challenge of vaccine hesitancy is not a problem of the vaccine of the information ecosystem, and it often has little to do with vaccine themselves. Again, emphasizing that in addition to, of course, having safe and effective vaccines, how we deliver the vaccine, how we deliver the vaccine message is very, very important. So next is nowcasting. Nowcasting refers to using the latest available data to inform different aspects of the epidemic. So in nowcasting, as some of you might know, when we try to characterize an epidemic, we get different data streams from different sources. And oftentimes, these data streams are fraught with errors and other reporting issues, which means somehow we have to piece together these different data streams in order to figure out what the epidemic is, how the epidemic is going on. So clinical and genomic surveillance have become part of nowcasting because of COVID, but behavioral and confidence surveillance remains fragmented and episodic. In particular, vaccine uptake data are available, but data about the underlying drivers are often lacking or lag behind, which makes development of solutions against vaccine hesitancy very, very difficult in real time. So that's one of the things that we have to work on, namely incorporating timely, near real time data on vaccine not just vaccine uptake, but also data about the underlying factors that are driving hesitancy. Digital advances is a double-edged sword in the context of vaccine hesitancy because it does facilitate the spread of accurate information, but at the same time, it also facilitates generation and spread of misinformation, as we witnessed during COVID. Once spread, misinformation is very difficult to eradicate. Once lost, trust is very, very difficult to regain, which is something that has been illustrated by recent prominent studies published in leading journals like Science and Nature. An article in Science shows that the spread of false information is much faster and wider on the internet compared to true information. The study on the right emphasized something that is intuitive but not often recognized as important. Namely, we've been paying a lot of attention on outright misinformation spreading in the digital space, but there are a lot more other information that is not outright misinformation, but sort of vaccine skeptical, ambiguous information. And these type of information are much more prevalent, 10 to 100 times more prevalent than outright misinformation. But collectively, the impact on influencing vaccine decision is much larger. So that's what the Science paper on the right shows. As mentioned earlier, real-time data on vaccine hesitancy and the distribution of these individuals are very important. Citing the example of Hong Kong COVID again, we had a large proportion of unvaccinated people concentrated in high-risk groups. In addition to that, these high-risk groups clustered together. In Hong Kong during that time, most of the unvaccinated elderly were residing in nursing homes, long-term care facilities. So this type of data will be very important for nowcasting because this clustering of unvaccinated people will have a very pronounced impact on vaccine, the impact of vaccination on the spread of disease. So these are the takeaways from my presentation. Timely acceptance was a critical weak link in the pathway of vaccine impact in many countries during COVID. Trust in those delivering vaccine messages is essential for building vaccine confidence, and trust cannot be searched on demand. And therefore, trust building must be a cornerstone of pandemic preparedness. We have to do this as a continuous measure, not start working on it when crisis happened. Uncertainty undermines trust. Nowcasting is the key for assessing, communicating, and reducing uncertainty during crisis. And therefore, in order to alleviate the problem of vaccine hesitancy during crises, nowcasting vaccine hesitancy must be improved. It was a major gap compared with clinical and genomic surveillance during COVID, and hopefully in the next pandemic, we'll do much better on this front. So that's all I would like to share with you this morning. Thank you very much for listening.
Thank you, Professor, and I apologize for the louder than intended bell during your presentation. I have a few questions from online, but we'll also work, if there's any questions in the audience, please do let us know. The first question that's come through, Agus Sayoruchaman, is there any program to reduce vaccine prices for low-income countries to increase vaccine coverage?
I think there are a lot of people have been working on that to make vaccines more affordable, accessible, available to low-income countries, including Gavi and CEPI. So I'm not in that area, but I know that a lot of people, a lot of investments have been put into that. Gates Foundation, for example, has been a key player in this area for funding.
Thank you. The next question is, given the use of COVID vaccines during COVID was without the full regulatory process, that created concerns. Has the full regulatory assessment been completed, and if so, has this information been provided and promoted to the public to overcome lingering concern, I'm assuming regarding COVID vaccines, as a barrier?
So my understanding is that in the States, for example, I forgot what the mission was called, but there was established a program, accelerated program to warp speed, exactly. Yeah, there was legitimate program enacted for the purpose of developing COVID vaccines and evaluating them just like regular vaccine trials, but in a much faster way. As we all know, bureaucracy could be a huge driver for friction in the approval of regular drugs and vaccines. But during COVID, I think those frictions were minimized in order for us to develop the vaccine faster and make it more available to the general public. So my understanding is that the process was as rigorous compared to what we do for vaccines in regular times.
It is at times difficult to explain to folks unfamiliar with the process, for example, what CEPI does in order to help accelerate the process.
Exactly.
Thank you. A question from the audience.
Thank you for your talk. I'm interested in the use of mandates to try and overcome vaccine hesitancy. Obviously with COVID, a fair amount of the vaccine hesitancy occurred because people were unhappy about mandates being introduced and required vaccines in order to rejoin the community. On the converse of that is a place like West Virginia, which is one of the most poor, socially deprived states in the US, but has always had a very strict mandate for school entry and various other things, where there's almost no exclusions available. You can't be conscientious objector or anything else. And there's been a number of measles outbreaks in the US where every state around West Virginia has measles, and West Virginia is measles free. They run at about 98, 99% coverage, and there the mandate works to actually protect the population. I mean, the current hesitancy is incredibly complex and difficult to fix with a single thing. But I just wonder whether the use of mandates in that sort of setting is actually going to help protect the public while we try and sort some of the other stuff out.
So a little disclaimer for myself. I'm actually a data scientist and epidemiologist. I started getting interest in vaccine hesitancy and started working with Heidi Larson before COVID. So I've been learning about the landscape and solution as well. One of the things I learned also related to what I said here, because trust is so important. Mandates is my own perspective. Mandate could be a short-term fix. Like you said, some people don't like to be coerced to do something, especially as a preventive measure. So it might work in some places at one time, but I imagine that there will be consequence, long-term consequence, in particular erosion of trust, alienating the specific groups that you just mentioned. So, and that's why in one of the studies that I reported here, 20% of people reported that, in the States, reported that they will be less likely to accept vaccine recommendation from the officials because of their experience during COVID, where 60% said they would be more likely. So it's like you said, it's a very complex problem. It's not as apparent or intuitive as the direct impact of vaccination. So when we think about vaccine effectiveness, we think about the protection that would be conferred to the person, and it's quite similar biologically. There's some variations, but not as large as the impact of vaccine hesitancy with respect to the interventions that are used to alleviating, especially mandatory measures. So, yeah, that's my take on that.
Thank you, Professor.
Thank you.
And we did have a couple more questions online, but unfortunately we're out of time. So
Thank
you
you
very much for your presentation. We'll move on now. If I could, one reminder to the participants, if you could silence notifications on your phone. We did have a few come through during that speech, so if you could just check and make sure that your notifications are silent, I'd be grateful. Thank you, everyone. We will now move on to session 1, Influenza, New Threats and Fresh Approaches, as chaired by Director of APACI, Kim Sampson.
Good morning, everyone, and welcome. As John mentioned, this is the influenza session, our first session for the day, New Threats and Fresh Approaches. We have 4 presentations. Each one will be 20 minutes, and there'll be a Q&A. It's included in the 20 minutes, yep. And then, as just happened then, there will be questions coming in online, and then I'll put those out there once they turn up. So please join me in welcoming Professor Ji Yun Noh from the Korea University Guro Hospital. She is a professor of infectious diseases there, and the topic is re-evaluating influenza vaccine strategy in Korea, evidence for improved protection in older adults. Thank you.
Good morning. I am Ji Yun Noh from the Korea University in South Korea, and internal medicine, the infectious disease clinician. So today, I'd like to talk about the re-evaluation of influenza vaccine strategy in Korea, and I suggest some evidence for the improved protection in older adults. So this is my disclosure. So the problem is why influenza vaccine effectiveness is low in the Korean older adults. Older adults carry the greatest burden of severe influenza. Immunosenescence and inflammation raise both susceptibility and severity of the influenza, especially in the elderly group. The annual seasonal influenza mortality is high especially in the older age group, and excess influenza and pneumonia hospitalizations were measured at 5 times more compared to those of 50s age group. And also the more than half of older adults failed to seroconvert to the individual vaccine strains after the standard dose immunization. In this figure, you can see the pooled vaccine effectiveness in preventing influenza hospitalization by the test negative design meta-analysis. So you can see the vaccine effectiveness declines with age. So this gap means the high influenza disease burden in older adults, and the older adults show the lower antibody response, and also the reduced B and T cell response following immunization. So therefore, the standard dose non-enhanced vaccine is less effective in the context of the immunosenescence. The Korea has one of the world's the highest influenza vaccination rate, however, the protection remains very low. Influenza vaccine uptake in Korea in the older adults is among the highest globally. It is more than 80% coverage annually. But however, pooled vaccine effectiveness against laboratory confirmed influenza in the older adults is only 30%, and it further collapsed in the mismatched season also. In Korea, the near universal use of egg-based vaccines combined with repeated annual dosing with the higher vaccination coverage rate, it creates a condition for the promotion of the immune imprinting by the egg adoption. In this study, this study is the meta-analysis with the test negative design study. It showed the pooled influenza vaccine effectiveness against laboratory confirmed influenza. So here you can see that the influenza vaccine effectiveness is lower in the older adults compared to the young adults. So in the overall 30%, and especially for the H3N2, a very low vaccine effectiveness counted as 17%. So this analysis suggests that the tailored vaccination strategies are needed for the older adults and also against H3N2. This is the major timeline is the national immunization program for influenza in Korea. In 1989, the seasonal influenza vaccine, the first became commercially available in Korea. And in 1997, the temporary national immunization program introduced targeted elderly people and patients with chronic medical disease and also the cardiopulmonary disease. In 2005, the free vaccination is implemented. The government subsidies free vaccination for the adult aged 65 years more. But at that time, the practice of the immunization is only conducted in the regional healthcare centers operated by the government. But after that, 2015, the expansion of the practice of immunization, influenza immunization, is expanded through the private medical institutions, so it can contribute to the accessibility of vaccination and convenience of the people, and also enhance the safety and also the coverage rate. So in this figure, you can see the influenza vaccine coverage rate in older adults in Korea during the 22, 23, and 23 and 24 seasons. So it is up to 82% in the older adults. From just the beginning of the national annual NIP for influenza, within the 1 month, the vaccination coverage rate reached to the plateau. In the right side, you can see the children in our country, children's NIP, the vaccination coverage for influenza. But however, despite of the high vaccination rate in Korea, unfortunately, the vaccine effectiveness against laboratory confirmed influenza in older adults is somewhat low in Korea. This is the study of our group. So during the 10 influenza season, you can see the vaccine effectiveness against laboratory confirmed influenza in the older adults. It is very low, and overall 3%, but not significant. And however, in 2016 and 17 season, the vaccine effectiveness is significantly the effective with 47%. So in the previous result is based on the university hospitals based on the data from the university hospitals based network. The network, the vaccine effectiveness study network, covers the adult patients more than 19 years of age, and our study included the outpatients with IRI visiting emergency department and outpatient clinic, and also the inpatients with IRI or laboratory confirmed influenza. So for hospitalized patients who did not present the typical IRI but test positive were also included in the study. So actually our study is test negative design, but it contains partially includes the SARI surveillance characteristics, including the already positive hospitalized case. And there is some limitation of our network. It is also only the tertiary hospital-based network, not included. The primary care clinic is not included. And the previous studies, we also do PCR, but the case of PCR is lower than the RAT case, number of RAT case, so there is some limitation of performance, the sensitivity of the RAT, and there is inter-site variation in patient enrollment. So there are factors that may explain Korea's effectiveness gap. The egg-adopted vaccine antigen may contribute to lower vaccine effectiveness, especially in older adults, and especially during the H3N2 dominant season. And our very high annual vaccination may repeatedly boost the immune memory against the previously encountered vaccine antigen, and it can direct the antibody response toward the prior strains rather than the newly drifted variants, that is the actual circulating strains. And also the H3N2 virus undergoes rapid antigenic drift, resulting in the frequent antigenic mismatch and lower vaccine effectiveness. So during the vaccine production of the egg-based platform, egg adaptation can occur, and then the vaccine-induced antibodies bind the egg-adapted virus well. However, the bind circulating viruses poorly. So when the egg adaptation is occurred in the vaccine, the production strain, and if there are some significant mutation in the RBD, that it leads to low vaccine effectiveness in this season. So I already mentioned about the high vaccination coverage rate for influenza in Korean older adults, up to 85%. But repeat influenza vaccination is of course effective. It is good. It is better than the not vaccinated. But also the repeat vaccination has some limitation because our immune system respond to the newer antigen. Respond to your antigen with the recall, the memory response. So if the first vaccine strain and the second, the followed vaccine strain has the high antigenic similarity, and also the epidemic virus strains have the lower antigenic similarity with the vaccine strain, it affects the lower vaccine effectiveness, the immune imprinting. And in addition, the characteristics of influenza virus is highly frequent of antigenic mutation, and also especially H3 virus type have the more frequent antigenic mutation. So in from our data, when the strain mismatches, there are measurable protection disappears in our data. For the vaccine effectiveness against laboratory confirmed influenza, and also the influenza hospitalization is significantly decreased in the mismatched season, the orange color. So the strategies, we know that there are two evidence-based levels, cell culture vaccine and adjuvanted vaccine. So compared to the egg-based influenza vaccine, the cell culture vaccine has many advantages. Antigenic fidelity, there are no egg-adaptive mutations, so cell strength maintains the authentic antigenicity. And manufacturing speed is very high, so it is key for the pandemic preparedness. And also the real-world effectiveness data shows a higher and equivalent vaccine effectiveness, the superior antigenic match, especially against H3N2. The real-world data shows the cell culture vaccine consistently outperforms egg-based vaccine, but relative vaccine effectiveness, of course, the modest, but the direction is consistent. The overall, the relative vaccine effectiveness is 7 to 20%, but magnitude varies by seasons and also the varies by the studies. This is more the current studies. It also shows the pooled relative vaccine effectiveness is 9%. So the more effectiveness, effective the cell culture vaccine, rather than egg-based vaccine. So in Korea, we have the domestic developed cell culture vaccine. So this is the cell culture vaccine effectiveness in Korean children. Overall, the vaccine effectiveness is 45% and higher protection in the infants less than 3 years age, and also higher vaccine effectiveness against influenza B than A. And this study highlights the importance of cell culture vaccine, the incorporation of cell culture vaccine instead of egg-based vaccine. So in these studies, you can see the discrepancy, this year 1 and year 2 study. You can see the discrepancy of the antibody titer to egg to cell ratio is lower in the non-egg vaccine, and year 2 also this non-egg arms, this discrepancy is narrowed. So this study suggests the multiple seasons of non-egg vaccination are needed to overcome the egg-adapted immune memory and redirect the response to circulating strains. So and also the MF59 targets the aged immune system, strengthen, broaden, and lengthen. And lengthen is the more durable titer is also important because in Korea usually the influenza season is until the April. And we know that the MF59 does bond mechanism. So there is some limitation in Korean strategy, but there is also the opportunities for the improvement. So in Korea, the Korean Society of Infectious Disease, the academic committee, will recommend for adult-aged older adults, enhanced influenza vaccine are recommended. But however, in Korean, NIP covers only the standard influenza vaccine. So we also have the statement of the statement that standard influenza vaccines can be administered as an alternative. So the adjuvanted and cell culture vaccines are mechanistically complementary. But however, in Korea, there is a potential barrier to uptake of enhanced influenza vaccine in the older adults. In Korea, the free NIP influenza vaccination is available, and annual vaccination coverage is very high. Enhanced influenza vaccine are recommended for older adults, but not covered by the NIP. So out-of-pocket cost may discourage the uptake of enhanced vaccine. It is my hypothesis. So the long-standing access to free standard vaccine may contribute to to low adoption of the enhanced vaccine. So last slide, I suggestedly evaluated strategies for older adults in Korea, the Shift to Older Adults program of egg-based standard dose, and pursue the combined platform as the strategic endpoint, adjuvant, it means adjuvant and cell culture. And also it is important that incorporation of the enhanced influenza vaccine into the NIP for the older adults, it can reduce the gap between guideline recommendation and real-world access through the public reimbursement. And lastly, we should generate Korea-specific effectiveness data and also the cost-effectiveness data. Thank you.
Thank you very much for that. We now have some questions coming through, and we'll be inviting them from the floor as well. So the first one that I have here, does a history of regular annual flu vaccination across lifetime versus those who only start flu vaccination over 65, does that impact the vaccine effectiveness?
It means the you means the.
So somebody who's been vaccinating all their life against influenza compared to somebody who simply starts at the age of 65, does that have an impact on the vaccine effectiveness?
No, I have no data.
Okay. Okay, this one, this is quite a long one. Referring to zoonotic virus, including influenza, human to human may occur when the host has the receptors of the vaccine virus and cellular machinery is appropriate for virus replication and shedding. Related to this, is there any definite genomic or proteomic data to predict that zoonotic influenza may cause epidemic or pandemic?
I'm not sure it is a question about regarding my presentation. Yeah, but yes, but so for the, you mean the zoonotic influenza viruses?
Yeah. Yeah.
We have the surveillance system for the zoonotic influenza virus, but actually there are officially no cases in human infected with zoonotic influenza virus in Korea.
Okay, thank you. Someone from the floor? Yes, there we go.
Thank you for your talk. I was particularly interested in the capacity of cell-based vaccines to overcome imprinting. That I hadn't seen that data before. I think that will be important as we look at that. Australia's been using adjuvanted vaccines for almost a decade with a really good response. Hasn't really decreased the amount of flu, but has substantially decreased hospitalisations with this, so it stops severe disease in the same way that COVID did. I'm interested in your view on the next step. I mean, I saw some very interesting data from mRNA 1010 compared to high dose, not to adjuvanted, but appeared to suggest that this may be the next step forward based on immunogenicity. Is that available, and have you had a look at that in Korea?
You mean the availability of the enhanced vaccine in Korea? The availability in...
Yeah, and have you had a look at the benefits of that over what we've currently got?
Yes, we have the high-dose vaccine and adjuvanted vaccine, but there is no the data. We have the cost-effectiveness data, but we don't have the vaccine effect, the comparison of vaccine effectiveness data.
And what about mRNA 1010?
mRNA, we don't have, not yet, we don't have mRNA vaccine, influenza vaccine, not yet.
Okay, look, we do have some other questions online, but to keep the meeting going, we'll finish. Thank you very much for that presentation. It was very, very interesting. And I'd like to now invite the next speaker. So, Jessica, Professor Jessica Wong. Jessica is the Research Assistant Professor in the Division of Epidemiology and Biostatistics at Hong Kong University and will be presenting Estimating the Disease Burden of Influenza in Hong Kong. Thank you.
Thank you, Kim. Thank you, everyone, for the opportunity to present with you some of our latest finding. So here in this talk, I'm going to share with you some of the latest and preliminary finding of disease burden in Hong Kong. So in Hong Kong, not just in Hong Kong, for influenza viruses is associated with substantial burden globally each year. And most of the influenza infections do not lead to symptomatic or severe illness. If you look at the severity pyramid on the right-hand side, for people who have symptomatic illness, starting from the bottom, some of them who is more severe, they will seek medical care. And then if they have even more severe illness, they may be hospitalized or even get into intensive care unit, ICU, or some of them may even die. But if we just look at laboratory testing, because the testing has got only limited capacity and is quite expensive, if we just look at the laboratory confirmed count, it may underestimate the full burden of influenza. And now, if we have got accurate burden estimates, it will be very useful to inform vaccination policies and to help with the pandemic or hospital preparedness and prioritize on some high-risk groups, including the older adults or children. Here in Hong Kong are some available surveillance data. And I'm showing here for the period from 1998 to 2024. The left-hand side here showing before COVID pandemic, the pre-pandemic period from 1998 until 2010 there. And then on the right-hand side is the post-pandemic period. We only have got 2 years of data available currently. For the first panel here showing the influenza activity, which is the influenza proxy, combining the influenza-like illness surveillance and the laboratory surveillance. And we have got the threshold 0.005 for during the study period, showing when the influenza season is. And then the second panel here showing the respiratory mortality, and the bottom panel here showing the respiratory hospitalizations by week. And I'm using this aggregate data to help estimating the influenza burden in Hong Kong. And out of this 21 years cover, excluding the SARS period in 2003 and the COVID pandemic period, these 21 years for the 2 influenza seasons is identified for 12 years out of the 21 years. And for only single seasons, half of the years among those single seasons, half of them has got prolonged influenza seasons for more than 5 months. And here in this talk, I'm gonna first show you some investigation that we have on estimating the mortality and hospitalization impact in post-pandemic period for the 2 years compared to the pre-pandemic period. And secondly, I'll show you some of our preliminary findings on the telephone survey on understanding the healthcare seeking behavior in 2026. And using that data, I try to estimate the medically attended burden in the post-COVID period. And here I'm showing you some of the idea of the methods that I'm using. The first part here to estimate the mortality and hospitalization burden. Here we're using the linear regression model on the outcome of respiratory death and hospitalization throughout the study period from 1998 to 2014. And in the model, we include the SARS-CoV-2 virus activity, and also the RSV activity, and include other covariates like the calendar, week time, humidity, and temperature as the covariate in the model. And with that, we estimate the hospitalization and mortality burden. And then the next part of the study, using the telephone survey that we conduct from March to May 2026, that includes the questions of asking the participants, around 2,000 participants in the survey, asking them the questions about their symptoms associated with respiratory virus infections and their associated health-seeking behavior, whether they seek medical care and what type of medical care they seek during the last 60 days at the time of the interview. And on the right-hand side here, the severity pyramid, I'm starting with the death and hospitalization on the top panel. So the first step, estimating the influenza-associated hospitalization. And then the second step, from the hospitalization level, I'm going down to calculate the symptomatic illness by multiplying the hospitalization burden by the case hospitalization ratio to get the bottom level of the symptomatic illness. And then I'm going up one level, step number 3, to calculate the medical attendant burden by multiplying the fraction of seeking care with the symptomatic illness. Here shows you some of the idea of how to estimate the influenza-associated excess mortality, which is at the top level of the pyramid. Step number 1 here, I'm applying the regression model to the mortality data, which is top on this panel here. And I've got data from year 1 to year 5. And using our influenza activity as a covariate in the model, the bottom panel here. And then step number 2, I'm estimating the influenza excess mortality as the difference between the predicted mortality that I got from the fitted model based on the reported influenza activity. And in a counterfactual scenario that I've got the fitted model, but I'm setting the influenza activity as 0, meaning that I'm assuming there's no influenza activity. So the difference between these two predicted values is my influenza-associated excess mortality. So this is part 1, looking at mortality and hospitalization impact. And I'm starting with mortality impact here, which is the excess respiratory is my focus here, excess respiratory death. And I'm showing, first of all influenza in the top panel, and then going down with different influenza subtype. Start with influenza H1N1 in panel B, and going down to H3 in panel C, and at the bottom, panel B. And for influenza, influenza-associated excess respiratory mortality, I saw that if you look at the top panel here in all ages, I see that there's a decrease from 7.3 to 3.5 per 100,000 population when comparing the post-pandemic. So 7.3 is the pre-pandemic estimates, and going down from 3.5 in the post-pandemic period. And if I go down to different subtypes, I'm seeing similar changes in H3N2 and B that is also have got the decrease. For H1N1, I saw similar when comparing the pre and post estimates. And if I look further on the highest burden part, on the older adult of 80 or above, I saw that the highest burden is associated with H3N2 during the pre-pandemic period. And then for post-pandemic period, I saw the highest burden in H1N1. And now I'm looking at the second level, which is the excess respiratory hospitalization by subtype. If I look at the first panel here, all influenza, and focus on all ages, I saw that influenza-associated excess respiratory hospitalization decreased from 200 in pre-pandemic period down to 85 in the post-pandemic period. And similar changes when I compare by different influenza subtype. I saw that similar reduction in H3 and H3N2 and B, but for H1 I saw a similar when comparing pre and post period. And if I look at for different subtype, but looking at the extreme age group, the kids and the older adult 80 or above, I saw that the highest burden is associated with H3 in the pre-pandemic period. And for the post-pandemic period, I saw that less than 1, H1 is associated with highest burden, but H3 endo is for the older adults. Then I'm comparing mortality with hospitalization and understanding the severity ratio of these two numbers. The first column here in this table showing the excess respiratory mortality. The second column here is the excess respiratory hospitalization. And then the third column is to look at the two number using death as the numerator and then hospitalization as the denominator. And then the last column here is the relative ratio when using H3 as the reference group and compare with the other subtype using H3 as the reference group. And from this table, we can see that the ratio is the highest when associated with H1N1. When you look at the pre-pandemic period, H1 is associated with the ratio of 93, but then the other subtype is less. It's 55 and 47 for H3 and B respectively. Then when look further to the estimated ratio of this ratio of death to hospitalization, H1 is the highest than H3 with the factor of 1.7. And now the second part of this talk, I will focus on the healthcare seeking behavior survey. This figures here shows the influenza activity by different years. And for this telephone survey, we look at the 2 months from March to May, and including in the total survey here with around 2,000 people and around 28% of the participants reporting acute respiratory infection, meaning that they have got at least 2 symptoms of respiratory illnesses. And among those around 600 participants showing ARI symptoms, 70% of them showing that they have seek medical care. In Hong Kong, we have 2 main parts of healthcare, private versus public. So for public, if people have got illness, they may be admitted to hospital, or they seek the care from the outpatient clinic in hospital, which is the general outpatient clinic, GOPC, or if they have got more immediate need, they may admitted to the accidents and emergency care, which is the ANE showing in these figures. For private, we have got the private general patient, which is the general practitioners here, GP. And if they want to seek traditional Chinese medicine, they can see the Chinese medical practice, CMP. So they're private and public in Hong Kong. And in these figures, I'm showing 6 different categories with private GP only, or general outpatient clinic, which is the public, or the traditional Chinese medicine, CMP only, or they ever visit the ANE. And then on the right-hand side here, the participants may visit both the GP and GOPC, both private and outpatient in the public. So it's still Western medicine. But then the last categories here, the participants may visit both the GP or GOPC and the traditional medicine. So they visit both the Western and Chinese medicine. And comparing the participants showing ARI symptoms with fever on the left-hand side, and then the participants with ARI symptoms without fever, and then by different age group, less than 16 to 40 to 54 middle adults, and then the adults with 55 or above, and then the all ages at the bottom. And from these 2 figures, we show that GP, the private general practitioners, and GOPC were the most used healthcare providers across different age group. And for participants with fever is around 69%, and similarly for participants without fever. And this is even showing, particularly for children, is even visiting more for GOPC and GP. And more participants with ARI symptoms without fever seek medical care from the traditional Chinese medicine. And we also see that there's the mix of healthcare seeking behavior, meaning that the participants are visiting both the Western and Chinese medicine, and more commonly in the older adults with fever from the light purple on the left-hand side. When we're comparing 55 or above, that light purple, and then compare to the two age group above, 55 or above is 22%, but then 0 to 54 years old is 13%. And then we next look at the duration from people with the symptom onset to seek medical care. The different categories here showing is immediate, the participant visiting the practitioners or hospital A&E immediate, meaning maybe within 1 to 2 hours. And then the next category is not immediate, but they visit within 1 day. And then the next three categories is 1 to 2 days, 3 to 4 days, and more than 4 days. And similar to the previous plots, I'm showing the 3 different age group and all ages. And comparing these two figures, I see that most participants seek cares within the 2 days from symptom onset. You can see at the bottom here, the 3 categories. With fever is 90%, without fever is 75%. And participants with fever were more likely to seek the care earlier than those without fever. If we just look at immediate and not immediate, but within 1 day, with fever is 48%, and without fever is 34%. And for older adults with fever, they tend to seek the care more immediate after symptom onset. If you look at the left-hand side, the 65 or above, the top, the left categories here is 13%, but we compare it to the 2 age group above is around just 9%. And here in this table, I'm showing the estimation of medically attended burden. The second columns here showing the excess hospitalization for different age group. And then the second column here showing the case to hospitalization ratio. And this is based on a published paper from the US in 2025. And then the fourth column is the fractions of seeking care. We can see that among the different age group, the fractions of seeking care range from 0.59 to 0.76. And the highest fractions of seeking care is the younger kids, 0 to 5 years old. And the last column here showing the estimations of medically attended burden based on the excess hospitalization, case hospitalization ratio, and the fraction of seek care. And we estimated that combining the all age group together, around 300,000 medical attended illness per year. And the burden was highest in the 2 younger age groups, 0 to 5 years and 6 to 17 years old. And here are the summary of the results. For influenza, excess respiratory mortality, we found a reduce of burden from 7.3 to 3.5. And similarly for hospitalization rates, reductions of 200 to 85 when comparing the pre to post-pandemic period. And compare with different subtypes, H3N2, compared with H3N2, influenza H1N1 is associated with higher severity, and around 300,000 medical attended illness per year among all ages in the post-pandemic period. These are the study conducted using the fundings from HMRF Fellowship and the HMRF grants. Thank you so much for your attention.
Thank you for that, Professor Wong. We do have a couple of questions that have come through, but look, there's one on the floor. Okay, we'll come back to that one. We'll get a mic over to you. So, the first one is about predicting severity. So the question is, in a country with 4 seasons of influenza transmission mainly occurring in winter, how can we predict the severity in a country with 2 seasons?
This is a very good question. Oh, sorry, they took away my slides. But if you remember the available surveillance data there, in Hong Kong, we usually have got 2 seasons, one winter, one summer. And compared to the, this is a subtropical Hong Kong, but then for temperate countries like in the US, they only have got 1 season. I think the way to estimate it is actually very similar. It's actually more difficult in Hong Kong because there's like 2 seasons. But thank you for raising that out. It should be like a similar kind of method, but it's actually like, it's more difficult in Hong Kong because we have to account for 2 different seasons and yeah. But
okay, thank you. Yeah. We'll take one from the floor.
Yeah.
Prof. Wong, great data sets. I was just wondering, your stark change between mortality before and after the COVID.
Yes.
What could be the drivers for that? I understand changes in behavior and everything after COVID. I was wondering, is it because of the COVID Grim Reaper that we had in Hong Kong that most elderly frail are already dead?
Thank you so much, Vijay, for such a good questions. This is also one of the questions in our mind, because this is just some preliminary, so we just got back, as you can see from the mortality data, because there's a delay in getting those mortality and hospitalization data. We're also looking at the driver. But one of the suspicion, because we're still investigating, we're using some other models looking at individual level data, which I'm not showing here, but hopefully I can share with you some of the results in the future. But say like the driver could really potentially be like the changes in the populations in terms of older adults, and also maybe there's change in the vaccinations, and also because there's change in the season. Because the plot is actually showing here, after pandemic period, we're only just seeing 2 H1 and 1 H3 season. We're hoping to get another year of data so that we can, because only 2 years of data is actually not really sufficient, and we're trying to get 1 more year data, and so that I can tell you more about the answer later. Thank you, Vijay, for raising that questions.
Thank you for that. Look, there are more questions online, and it may be that we can follow up with the speakers after with those questions. So thank you again.
Thank you very much.
Thank you. So our next esteemed speaker is Professor John Tam. John is currently the visiting professor at the Department of Applied Biology and Chemical Technology of the Hong Kong Polytechnic University. He is also a former and founding chairman of APACI, and he will present the 2025 update to the WHO Public Health Research Agenda for Influenza. Please, John.
Kim, and thank you everyone being here. Today's topic I'm going to share with you is on the WHO Public Health Research Agenda for Influenza. This is a 2024 update, and I was working with WHO before, and the team is there, put up all the experience that they had, and then trying to move on with a lot of consultation with a lot of specialists and experts around the world on this very big process. So why do we need to have influenza vaccine, influenza research priorities? Because we continuously seeing outbreaks of influenza in animals, and the outbreak of animals are spilling over to humans. So we have an increased risk of zoonotic concerns. So that's why we have to update the research agenda, because when I talk about history, we will know about why we want to call it update. Okay? And then want to look for what are the future directions that we're going. And then a very important part of this process is to actually looking for future funding facilities, funding of research in these multiple different directions within the flu, public health in flu. So how was the research agenda developed? First one was in 2009 was published, but in the process in 2008, I was actually in WHO working there, and I was in charge of this program. And we organized a global consultation to develop the first research agenda. And the agenda was built upon a number of WHO publications looking at the WHO Global Agenda for Influenza, and then the WHO Strategic Action Plan for Pandemic Influenza. Because during that time, it is also anticipated that we will have, not whether we will have, but when, the question is when do we going to get the next pandemic? So we need to be prepared. So introducing topics for research and trying to answer questions and hopefully be able to mitigate future pandemics is the main purpose of developing the research agenda in 2009. And after it's been published 2009, the process was repeated again on reviewing the progress and new directions of research in 2013, which is a small review. But in 2017, we feel that it is necessary to have an overall re-examination of all the research priorities for public health influenza. So there was also a global consultation was done in 2016, and then the result was published as an update in 2017. So what we try to do in the new one, 2024, what do we want to look at for progress since 2017? There's a gap because we're supposed to have an update every 5 years or so, but then this time we only do it in 2024, 2023 and 24, simply because we are in the middle of the COVID pandemic, and that slowed a lot of things and draw a lot of attention and expertise away from flu to address the COVID thing. But in fact, it is extremely beneficial for us to looking at pandemic preparedness and mitigating ways for looking at influenza, because a lot of things are very similar. So the key achievement that we've seen since 2017 is there are big advances in vaccine development, okay, and there have been improved diagnostic tools and also changing diagnostic algorithms in clinical settings. We have enhanced surveillance systems, monitoring also carryover from COVID to flu. And then you can increase understanding of influenza virus dynamics to be able to do predictions in the future, because we are being able to predict the severity to a greater extent than before. So the remaining challenges that we have is vaccine efficacy, maintained to be an estimation. We can't have more accuracy in terms of looking at efficacy for vaccines. So a global coordination is needed to combat flu outbreak effectively, because we have all this experience from COVID. And then funding gaps is an important issue, that pooling a lot of the attention of funding agencies to go back to flu, because in many ways, respiratory tract infection seems to be the one that's driving a lot of pandemics that we were anticipating in the coming years. So 2024, we look at address knowledge gaps. That means we have to identify what they are first. So we have to identify knowledge gaps, identify new key research topics, and support under-resourced countries. This is a new one because when the first research agenda was set up, it wasn't paying attention to low and mid-income countries' research priorities. We're looking at the global view, but now we are paying a lot more attention to low and mid-income countries. And then facilitate collaboration and with discussion, particularly with global funding agencies. Okay, so for example, we have initiated a lot of discussion since 2009, the first version of Research Agenda, to discussion with the NIH in the US, Wellcome Trust, and so is ASEAN organizations of looking at how topics can be funded from local. The other one is there are topics that really cannot be handled by one single, even though whatever big institution they are, they still not be able to do some projects. So what we try to do is having funding agencies to do collaborative studies to support multiple partnership in the world to address certain topics that is global concern. So the work stream overview of how we're going to go about and do that is looking at reducing pandemic risks, limiting the spread of new viruses, minimizing impact when it happens, optimizing clinical management, promoting public health tools, and effective risk communication. These are the topics that we want to incorporate as was incorporated in the 2009 research agenda, but then we want to re-emphasize that these are still maintained to be a direction that we will go in terms of addressing public health research in influenza. So the process, the roadmap is in 2024, we started establishing what we call each one of those directions is streams of research. With the working group, we established a working group from over 85 different individuals from close to 30 different countries, putting them up into different groups. And then we apply for, of course, approval from WHO and the funding and so on. And then we're going to, starting from March to May, is to look at each of the research stream, what are work required for it, which is doing literature review, trying to identify what have been achieved and what are the knowledge gaps. And then we have virtual meetings in May to June in 2024. Virtual meetings, we have carried out total of over 50 teleconferences through different parts of the world. And unfortunately, I was living in Vancouver, and we are actually 15 hours earlier than Hong Kong. So you can imagine, we have Australia, we have Europe, we have US, the timing is totally terrible. So my teleconferences for that month is actually 4 o'clock in the morning or 5 o'clock in the morning. So a lot of hard work. Then we have the global consultation. We have a group of experts from the different work streams go to Geneva and discuss the finalized version of the research agenda. And we finalize the draft, and then we have multiple different reviewers at WHO to look at it, and then we published it. So we have expert review, we have global review. Global review is that we send the draft version of the research agenda out to ask for opinion from different parts or different research institutions. We come back with their comments and changes, proposals, and so on. So how is this organized, this work? The work related to research agenda is using different work streams. Work stream 1 is reducing the risk of emergence of pandemic influenza. 2 will be limiting the spread of pandemic, zoonotic, and seasonal epidemic influenza. Stream 3 will be minimizing the impact of pandemic, zoonotic, and seasonal epidemic influenza. Stream 4 is optimizing clinical management of patients with influenza. And Stream 5, which is on promoting the development and application of modern public health tools to address influenza public health research. The last one, which is a new one, because before we only have 5 work streams, we experience and also knowledge that we have gained from, we talk about that today about Professor Wu from Hong Kong, you talk about hesitancy and so on. We have to think about enhancing risk communication, community engagement, and infodemic management. So this is a topic, I'm a virologist, this is something really totally new to me. So I learned a lot from this particular stream. So how do we do the proposed research agenda to the world? It actually, we have stream, of course, all these 6 different streams. We have substream topics, identifying areas in that particular stream that need to be addressed. And then within each one of those substreams, we have areas of interest. Of course, the stream and substreams, we have to develop strategic objectives and also relying on systematic reviews and knowledge gaps, identification, and so on. So we have areas of interest being identified. For each one of the areas of interest is related to one of the substreams, and then we have research directions. This is a new way of organizing it. Because before, we only up to areas of interest, but then it will be a very broad question that we can't really describe, we can't really measure achievement in that particular area. So we make it into a way that we create research interests. Each one of those research interests should be able to stand alone and be a research proposal. Okay, that can answer a whole lot more other questions subsequently. But the idea is to making sure that research directions are actually grant proposal topics. Okay, we hope to be able to do that. So let's see stream 1, okay? Reduce the risk of emergence of a pandemic influenza. So we identify this as important to actually to improve surveillance and detection, understand the factors that contribute to viral emergence and transmission, and implement effective prevention and control measures, and develop improved vaccines for both animals and humans. So we have strategic direction objectives being established, and we identify areas that we should be prioritizing that is most needed due to our identification of research gaps or knowledge gap that we have in this direction. So this is one, and then we go to substreams, right? Like for example, improving surveillance and detection, and then substream 1.2 will be host and environment determinants of infectivity, susceptibility, transmission, and pathogenesis. Okay, so you can still see that even if it's a substream, the topics is really wide. So we want to concentrate more later on. Okay, where we have areas of interest and then research direction. So just to give you some idea how this is done. So like, for example, substream 1.1, we have areas of interest of systems for expanded, comprehensive, sustainable, and transparent influenza virus detection and reporting. Okay? And also address funding, social, political, economic, and legal considerations. When we try to expand surveillance, these are things we need to look at. And improve virus detection, okay, especially in the animal-human interface and the environment, and then improve serological strategies and associated laboratory testing. This is a new way of doing surveillance. And then conduct research on using for more sensitive, specific, cost-effective, and operational convenient surveillance, so in animals and also in livestock. And then the last one is also in looking at wildlife. And then from each of those areas of interest, we developed research questions. So for example, for looking at one system expanded, comprehensive, sustainable, transparent detection and reporting of surveillance, looking at investigate approaches for funding for implementation of expanded surveillance. So we have to look at how we would be able to get more funding. And looking at perform study to address social, political, and legal issues for expanded surveillance. And then develop research on strategies for the implementation of expanded surveillance system. So each one of those is a research proposal, but of course there's a whole lot more questions under these particular areas of interest. So we only get up to here, that hopefully be able to concentrate people's thinking and probably align with what researchers, the proposal would be. And hopefully we'll be able to do that in that way. Now, of course, if I go through the whole document, we don't have enough time. We'll probably need a whole day. So the stream 2 is a limiting spread. So we have to understand the mode of transmission, elucidate the characteristics that allow stability of the virus in the environment, identify host factors, including existing immunity before exposure and immunological response after exposure. So this is a bit more broad. And then looking at environmental factors that can contribute to influenza virus transmission. So we're looking at that to develop our priority areas. So the substream topic will be identify factors affecting person-to-person transmission, enhancing and evaluating tools and approaches for influenza surveillance to improve understanding of global and local influenza circulation. And then evaluating the effectiveness of pharmaceutical and non-pharmaceutical interventions to reduce influenza transmission. So it's very big topics, but you can understand the logical way of putting them together and the logical way of stimulating thinking further, what needs to be done in terms of research. Hopefully you'll be able to come up with a research proposal, and hopefully funding agencies will be able to pick that up and say, this is the logical way of looking at it as related to the other areas of influenza, public health influenza research. Stream 3 will be minimizing impact. So continue research in further improving disease burden assessment. So disease burden keep on changing because of underlying medical conditions or environmental areas, or for example, you're in the isolated island. So what are the disease burden assessment that you will have? How does it different from the other ones? Enhance vaccine deployment, improve vaccine development, enhance vaccine deployment to optimize public health policies. So this one is actually specifically to address the needs of low and mid-income countries. How are they going to be able to obtain vaccine? How are they be able to build their own supply of vaccine sources, or maybe even manufacturing vaccine on their own? Okay, so there are a number of other different initiatives in WHO to do that. So we have that. And then we look at determining disease burden and social impact substreams, improving immunogenicity, availability, and delivery of influenza vaccines, development of improving public health policy to reduce the impact of disease. So these are big topics. Number 4 is optimizing treatment or clinical management. So advanced research on influenza pathogenesis and disease severity, and improve clinical management of patients with influenza infections. So there's upstream looking at identifying factors associated with pathogenesis and clinical severity, and improving clinical management of patients of influenza. So this is a lot of very active research, and they are not only research for influenza. Outcome from this kind of research is going to impact other diseases, such as, well, COVID is one, or pertussis is coming up, or any other RSV, for example, or any new respiratory tract infections coming up. Improving patient management will help. Of course, they are not specific, but overall, how to handle clinically. The other one that's very big in discussion was how do we deal with surge capacity needs in hospitals? Let's say suddenly you have 1 million people trying to look for clinical help or being admitted to the hospital. There's no way you can cope anywhere. So how will we be able to do that? Can we do that in the community? Can we do that? So these are being discussed. And Stream 5, promoting the use and the development of applications of modern public health tools. So one of them is this recent advances in rapid diagnostic technology, real-time data collection, expansion of clinical genomic surveillance. Okay, so this is next generation sequencing and modeling studies are very, very much more advanced and new public health tools. Next generation, integrating modeling in public health is a very big topic here, modeling and how accurate they are and so on. And then you have the final one, which is a new one, looking at research should focus on understanding how information and misinformation spread through digital and traditional networks, and identifying communication strategies that foster trust and improve public acceptance of recommended public health measures, and develop innovative tools and technologies to advance the science of risk communication. So these are the objectives. These are things that we need to do. So we have talk about substream is on strengthening risk communication and community engagement, improving infodemic management, and developed communication tools and technologies to improve risk communication, community engagement, and informatic management. So this is a brand new branch, in fact, in terms of all this, but they'll now become more and more important because of the COVID, what we have learned from COVID pandemic. So how can we use such a big topic of such big publication in terms of research? Give you an example. If someone needs to do research priority, let's say related to H5N1, all these animal viruses been expanding. So you try to pull questions, research question out from the different streams of work. For example, like you want to look at biological characteristics. There's 1.2.2a, which is from stream 1, substream 2, areas of interest 2 and A, right? So let's investigate virus-specific factors associated with zoonotic, reverse zoonotic, and pandemic potentials. So these are research questions. You want to work on X5N1. Then these are questions that you can pull out and identify what you can do, whether you be able to do that in your area, or whether you have the tools to manage that and be able to generate more specific and interesting results to help public health management of X5N1 or X5N6, all these different things. It doesn't have to be 5, it could be H9N2 or the others, okay? Like prevention control strategies, we pull all these questions out, but they could be all from different substreams or different streams of research. Clinical characteristics, surveillance and risk communications. So these are very helpful tools. Let's say you want to establish a better hospital management system. You do the same thing and go in there looking at. You start looking at diagnostic tools, which is different substreams, looking at availability and efficacy of vaccines in your community, what are they, and so on. So it's all very extensive in a way, and also many of those topics are cross-cutting. Cross-cutting, what I mean is, for example, a topic of surveillance. Surveillance. It doesn't have to be only surveillance for active disease cases. It could be surveillance of animals, surveillance of humans, surveillance on vaccine usage, surveillance on disease burden, and all of these are coming from different areas. So you can do that. Or if you want to do informatic research, you identify for flu, so you look at the different things that people have raised and prioritized. So this is the team that we have from WHO, that we have done quite a bit of work, in fact, for the group. And this is the QR code that you can go and assess and obtain the draft publication. And with that, thank you very much for your attention.
Thank you, Professor Tam. Very interesting. Are there any questions from the floor? There is one question, I think, that would, which is quite interesting. Sorry. So, how realistic is limiting zoonotic spread? Australia has a natural advantage of remoteness and being an island continent, yet avian influenza has now been detected. Please comment.
That's the reason why you have the X5N1, right?
Yep.
Two cases. Because the result of enhanced surveillance system. Because you have that system in place, and now you're trying to look at, now we have it, what do we do? So you ask the research, what needs to be done? How do we contain it? Okay. What other animals are being involved in this? Is it going to, it's already spreading to human cases already, right? One.
I think one, yes.
One.
Yeah.
So then you start looking at what factors allowing this person to be infected. Is it being close? Is it work? Is this person working together with the avian viruses? Is it working together in the field as an abattoir worker? All these questions start to come out, and you generate a pattern how the virus is being spread in Australia. So this is useful for you to be able to look at, multiple different things and identify the right question to ask.
Well, on that note, thank you very much. We'll keep moving.
Thank you.
And thank you, everyone. And so our next speaker is Professor Paul Tambyah. Paul is a Professor of Medicine at the National University of Singapore and a Senior Consultant Infectious Diseases physician. Paul's talk is going to be the research response to pandemic influenza. Thank you.
Thank you very much, Kim, and thank you for inviting me to this meeting. I always like to come to Hong Kong, and yeah, there you are. So I realize I'm standing between you and the tea break, so I'm going to try and keep it short. As you know, the Strait of Hormuz has been in the news recently, and this quote resurfaced where a British admiral 100 years ago pointed out that there were 6 keys to the world, and one of them was Singapore, because Singapore sits at the center of global trade. And Singapore is very conscious of our position as among the busiest ports in the world, and for some reason we only compare ourselves with Hong Kong. Okay, we don't care that Shanghai has overtaken us. But the point of all that is that as a center of global trade and tourism, we've seen every pandemic that there has been, from 1918, 1957, 1968, 1977, and 2009. Interestingly enough, none of those pandemics had an impact on life expectancy except for the COVID-19 pandemic, where we saw for the first time a dip in life expectancy in Singapore. And I was puzzled about this, so I had a couple of students try and analyze why the life expectancy in Singapore dipped during the COVID pandemic, despite the fact that there were so few reported COVID deaths in Singapore. And what we found is really interesting. Traffic accident deaths dropped dramatically because we had, much reduced movement of people. Suicide deaths remained about the same, but deaths from cancer and hypertensive heart disease went up. So one of the things that we think is that people were just scared of going to see their doctors. And so the unintended consequences actually kicked in. Anyway, as you can tell, I have an interest in history. So one afternoon, I went to the university library and I started looking up the 1957 pandemic. And it's quite interesting because, again, as usual, from way back then, we blamed Taiwan and Hong Kong for the origin of the pandemic. And this was in May 1957. But within 2 days, Singapore has always been one of the most crowded cities. Within 2 days, it spread all over the city. 25,000 people, students were sick. So they had this decision about whether to close schools or not. And they actually didn't have to make the decision because the schools just closed themselves. And what was interesting is the researchers at the University of Singapore managed to isolate the virus, and they sent it to Australia, to the reference lab, McFarlane Burnett's lab, actually. And this was published in the British Medical Journal by Professor Lim Kok Ann, who was actually a famous chess player in addition to being a virologist. And he tells a really interesting story about how he picked it up. So these were workers at the British naval base in one of the islands off Singapore. And these workers were what's known as daily rated workers. In other words, if they don't go to work, they don't get paid. But these workers actually reported sick on May Day, 1st of May, which is a public holiday. And people don't report sick on a public holiday unless you're really sick. So he went to the island. He was informed about that by the naval base doctor. He went to the island. He swabbed a bunch of these workers. And he discovered a virus which did not react against antiserum to the existing circulating H1N1. And so he sent it over to McFarlane Burnett, and he confirmed the fact that this was a novel strain of influenza. At that time, and what he did was he grew them in embryonated eggs, which he picked up from a chicken hatchery at Crawford Street, which is right in the heart of downtown, which nobody visiting Singapore right now can imagine used to be a place where chickens were bred. But in any case, he did not have to do an MTA or a clinical trial agreement, which is currently the bugbear of every researcher. I don't know if any of you have tried to collaborate in Singapore with researchers in Singapore, but trying to get samples or data from Singapore to anywhere in the world is a nightmare. Well, I guess it's almost as bad as getting information out from the mainland. So anyway, so he sends the samples to Australia. They're confirmed, and meanwhile, the epidemic goes all the way up Malaysia. And then it's confirmed that this indeed is a novel strain, the H2N2. And it took a while, but again, flu burned through Singapore really quickly. That's the advantage of being a small, crowded city. And it started fizzling out within a couple of weeks. And it spread to Japan. 2.5 million people in Japan were reported to have influenza. And of course, there were all kinds of quack remedies that were being pursued, including Scott's emulsion, which my mom made me take as a kid. And that was the 1957 pandemic, which again, we were so happy wasn't called the Singapore flu, even though it was first described in Singapore. But in between, we had 68, then we had 77. And there was a lot of anxiety in the early 2000s about bird flu, the H5N1. And this actually came to the fore in an editorial in the Wall Street Journal, where it was commented that the US State Department was considering putting the whole of Southeast Asia on a travel advisory because of the emergence of H5N1 in Indonesia and Vietnam. And we knew what travel advisories do, and I think you all knew this too. In 2003, we were hit by the SARS epidemic. And the SARS epidemic, which many of us forget, occurred at the time of the Second Gulf War. And there was a Singaporean teacher who was in Kuwait, and she said it was between getting bombed here and going home and getting pneumonia, and she decided to stay in Kuwait. So it was that bad. So there was a clear decision to really not allow that to happen again in Singapore. And the biggest problem in Singapore was we do not have vaccine manufacturing capability. You know, they've tried for years and years and years to get vaccine manufacturers to set up shop in Singapore. We have all the infrastructure, we have very good scientists, we have a lot of other ingredients for successful vaccine manufacturing, but the cost has just been too high. And so with this threat of a travel advisory, Singapore's, and again, this concern, which interestingly enough has resurfaced in recent years with the H5N1 in the US, the Singapore Economic Development Board approached Baxter to try and persuade them to set up a plant in Singapore. And they dangled as a carrot the option of doing a phase 1 clinical trial in Singapore of their H5 vaccine. And they asked, I knew the person who was the officer in charge, and she said, would you like to be the PI on this trial? And I said, you know, I've never done a phase 1 vaccine trial. And so I called up Malik and asked him, I said, so is this legit? Does this vaccine work? Is it going to kill people? And he said he looked at the preclinical data, and he walked me through, and he kind of held my hand as I was getting ready to do this study. And so the trial was set up to be in Singapore, in Hong Kong, and in Austria, in Vienna. And then unfortunately, this was around the time of the Northwick Park incident, which I'm not sure whether any of you remember. But this was an incident in a clinical trial unit in the UK, in Northwick Park. And what had happened is they had given a biological product to 6 individuals, and they had triggered a massive cytokine storm. All 6 of them ended up in the ICU. And fortunately, they survived. And this was early 2000s when Hong Kong was still very susceptible to British tabloid media. So there was a huge negative pushback, and Malik said he just couldn't run the trial in Hong Kong. So it became Singapore and Vienna. And then the regulators called me up and said, do you still want to go ahead with this trial? I said, so I called Malik and I said, why did you pull out? He said, was there a scientific reason? He said, no, it's just a public, you know, this communication thing that we've been talking about. So I said, okay, we'll go ahead. So I told the regulators we'll go ahead. Then they said, don't vaccinate the first patient. Let the Austrians vaccinate the first patient, wait for 24 hours, and then you vaccinate the next patient. So we told the Austrians that, and they said that actually makes sense. They said, we'll vaccinate the first patient, we'll wait for you to vaccinate the second patient before we vaccinate the third. And so it was, and again, this is the thing about Singapore. We've got really rigid regulators, but if they trust you and they talk to you and they know you're talking to somebody credible overseas, you can negotiate something. So we did the trial, and it worked. It eventually got published in the New England Journal of Medicine. And what we found was, so this is a virocell-derived vaccine because, as you know, H5 doesn't grow well in eggs. It kills the cells. And through various measures, again, the editors made us do all kinds of analysis. We had to actually do single radial hemolysis, which I don't think anybody did. We found one person in Italy who did it. And so we sent the samples to her, and she did it. But we showed that it did work. And this regime, interestingly enough, the unadjuvanted worked actually as well, if not better, than the adjuvanted. So, as I mentioned, I'm a clinician. I'm not actually a virologist or an immunologist. And so as clinicians, we look for all kinds of different approaches. So in addition to vaccines, I got myself involved in therapeutic trials. And at this time, one of the questions about the high mortality associated with H5N1 in Southeast Asia was whether we were underdosing patients. So there was an editorial, again, written by Nick White, and he argued that we should double the dose. So we ran a clinical trial. I got involved in the Southeast Asia Influenza Clinical Research Network, which was funded by NIH and the Wellcome Trust. And they funded all the sites except Singapore, because Singapore is a high-income country, so they won't fund us. So we had to get funding from the Singapore National Medical Research Council. And we ran the trial, and it wasn't only H5, it was severe seasonal influenza as well. Where the bottom line is that there was no difference between the double dose and the single dose of influenza, oseltamivir. So with all this panic about H5 and avian influenza, as you all know, it was actually swine flu, or the H1N1 2009, which came out in 2009. And our epidemiologists did some really good epidemiology work, and we had been preparing for a SARS-like outbreak in hospitals. But it turned out the big focus of the outbreak was actually in a nightclub. And this is a place that was free. It was run by 3 former lawyers who quit the law and set up this dance club. And interestingly enough, the super spreader was the bartender. So what they found were there were groups of students, there were groups of young workers, including groups of high school students with fake IDs who actually got infected. But everybody goes to the bar. So the bartender was working while sick, and so he was the one who was essentially transmitting the disease. Now, in Singapore, we have compulsory military service. So every young man, myself included, from the age of 18 to 21 has spent 2.5 years in the military. So we spent our time in the military Monday to Friday, but on Saturday and Sunday, we're out, provided we didn't do anything wrong. And so on Saturday night, they're all out at the clubs. So where did this outbreak manifest? It manifested in the military. So we had cases in various military camps. And at that time, we were using a quarantine approach. So the military followed the standard guidelines, quarantined everyone who had been in contact with these young men who got infected on Saturday night at the club. And this is before smartphones. So in Singapore, they put cameras in your home. And people in Singapore are very clever. See, they would put a photograph of themselves in front of the camera. So what they would do is they'd call you up and they say, wave your right hand, wave your left hand. So just putting a photograph doesn't work. But it's very intrusive. And so the chief of the Army Medical Corps calls me up. He's a friend of mine as well. And he says, look, you know, I've shut down 1 camp, 2nd camp, the 3rd camp. He says, I might as well open the door and let Al-Qaeda walk in. He says, is there an alternative? So I said to him, well, in nursing homes, if you have a case of influenza, you give oseltamivir as prophylaxis to everyone else in the nursing home, and it works. So he said, fine, you know, the military budget never gets questioned. I can give oseltamivir to everyone in the armed forces. Then he says to me, are there any side effects? So I said, well, you know, there's 1 in 10,000 who get neuropsychiatric side effects. He says, well, you know, we've got 30,000 soldiers in the armed forces. It's not a secret. It's in public information. So 3 of them are going to get neuropsychiatric side effects. Can you tell me whether these 3 are not going to be the guys holding a machine gun in front of a colonel? And I said, there's no way of telling that. So he said, what are we going to do? Then I said to him, you know, during the smallpox eradication effort, the original idea was to vaccinate the whole world, but that just proved impossible. So what they did was they found individual cases, offered a reward of $1,000 US in the 1960s, which is a lot of money in a village in India or Africa. And then they ring vaccinated people around it, and it worked. So I said, why don't we try that? We ring vaccinate, so we find cases of influenza in the military camps, and then we ring prophylax and offer chemoprophylaxis to people in the same bunk or in the same kind of unit. And so there were 4 outbreaks that we picked up involving about 800 contacts. And they were people who, you know, they were not necessarily in the same unit. They went to the canteen together, or they were in various other activities. And what we showed was by using a prophylaxis approach, we didn't have to quarantine anyone, but we actually ended the outbreak about a day earlier than we would have done if we had used quarantine. So effectively, the military was allowed to continue functioning. The soldiers continued doing. Singapore military doesn't fight wars, but we do plenty of exercises. So they continued doing that. And the savings was tremendous. We did the whole genome sequencing just because we could. And essentially, because we only gave it to 800 people instead of to 30,000, the number of side effects was actually relatively minimum. So that also got into the New England Journal, which was very nice. And then, of course, COVID happened. And our initial strategy involved a no lockdown approach. But then, you know, the trouble with lockdowns, and again, like I mentioned, I have many friends and collaborators in Hong Kong. Julian Tang, actually, who is no longer in Hong Kong, but he introduced me to colleagues who are modelers. And I'm not a modeler, but I have tremendous respect for their models. So they showed that if you have a lockdown, you effectively prevent transmission between households. So, you know, if you don't go out, you're not going to spread a virus to somebody else. But what you're doing is you're increasing transmission within households. So if it's the average Singapore household, which is 3.2 people, that's not a big deal. Unfortunately, we have in Singapore these migrant worker dormitories, which in a room like this will have maybe about 50 or 60 people living. And so when you've got household sizes which are enormous, you're going to get massive outbreaks. And true enough, we did have outbreaks of COVID in the migrant worker dormitories, and it was exacerbated by a fear that the healthcare system wouldn't be able to accommodate these crowds. And so we isolated the dormitories. So essentially people were stuck in the dormitories. They couldn't go out. They couldn't go to hospital unless they were really sick. And this was similar to the Diamond Princess strategy adopted in Japan. So these poor migrant workers, they felt that they were like sitting ducks. The attack rates ranged from 40% to 80%, depending on how crowded the room was, how good the ventilation was, and how sick the index cases were before they were picked up. So what we did was we had volunteer teams going in there, identifying those who were sick, bringing them to hospital, and of course all the other regular services were closed. So a neurologist friend of mine went in there, and he said, these guys need something done. So he said, can you do a prophylaxis trial? So I said, fine. So we ran a prophylaxis trial using 4 arms: hydroxychloroquine, ivermectin, povidone iodine, and zinc. Unfortunately, at that time, there was this fake study that was published in The Lancet showing that hydroxychloroquine was killing people. It turned out to be false. So again, the regulators came up to us and they said, so the UK hydroxychloroquine trial was canned, or at least put on hold. So we had a very complex consent process. We had speakers in the native languages of the workers. We had videos done in their own languages to get them to understand what they were signing up for. We did an ECG for every single patient, worker randomized to hydroxychloroquine, and we excluded anybody with even a PVC or an arrhythmia. And the results surprised us, because what we found was that both povidone iodine spray as well as hydroxychloroquine actually reduced the incidence of COVID seroconversion, and povidone reduced symptomatic disease. So we wrote it up, sent it to the New England Journal and the Lancet, and they both rejected us. We sent it to JAMA. They gave us a whole list of questions. We answered all their questions, and they still rejected us. And what they told us was, we find it very hard to publish anything that shows that hydroxychloroquine is good. In fact, one of the funders said, can you just hide the hydroxychloroquine part and talk about povidone iodine? But we eventually got it published in the International Journal of Infectious Disease, which happens to be the journal of the International Society of Infectious Disease, which I happen to be the president of. No conflict of interest there. But and we got an editorial from Nick White, again, who's one of the gurus of infectious disease, who sadly passed away just recently. And it got featured in the media. It got picked up by the NHS, who invited us to do a presentation. And Nick finally got the UK study done, and it found similar results, a small but modest reduction in a prophylaxis setting. So we've been trying to do these clinical studies on influenza for the longest time. And I put up this slide to encourage younger researchers. So in Singapore, we have this large collaborative grant. So I started applying for this in 2011. You can't see it. But it got rejected. We changed the PI. I had Gavin Smith as our PI. We changed the PI to Linfa. Once they said it was too broad, then we included one virus. And then finally, we got it funded. And what we did is we've taken part in the REMAP-CAP trial. Some of you are familiar with that. So it's basically adaptive platform trials where patients can consent to multiple different interventions. These interventions can be dropped if they don't work, or they can be preferentially recruited if they do. We are the center for a regional network, including other Southeast Asian sites. So there's a regional coordinating center, regional management center. Matt Cove and I are on the International Trial Steering Committee. And we've just published our most recent analysis, which is for influenza and steroids, where we showed that there was no benefit in adding steroids for that. This one was just presented a couple of weeks ago at CCR. It hasn't been published, but you can go to their website, you can hear the presentation, and it's very interesting. I'm not going to spoil the surprise by telling you the results. But ultimately, so this is actually freely available data on Singapore's research funding landscape. And what you can see is during 2020 and 2021, all of a sudden, infectious disease research got a lot of funding, obviously, because of the pandemic. And the cancer labs were all shut down. But very quickly, it was forgotten. By 2022, 2023, cancer goes back. It takes 10 times the amount of research funding that infectious disease gets. So I would argue that, people say never let a good pandemic go to waste, but it's how we use it and how we get set up in terms of the infrastructure, in terms of building the horizontal platforms, getting involved in large collaborative networks, making friends with people in other countries, in other fields. And ultimately, I think that's the way to go in terms of responding to a pandemic. So this is our meeting in Madrid. Madrid's a great place to go. November will be nice and cool. ISID, thank you.
Thank you, Paul. We do actually have about over 150 people online, but I've got the feeling that your presentation... Oh, actually, no, we do have one. I was going to say it was so thorough that... but here we go. If, as was mentioned, H1N5 avian virus does not grow in eggs, is it plausible that egg-based influenza vaccines may provide protection for avian H1N5?
Yeah, I mean, I guess that's a bit of a tricky question. And one of the things we're actually exploring is cross-protection from pandemic H1N1, egg-based H1N1, because there's a fascinating piece of epidemiologic information. I don't know who picked it up. I just completely escapes me. But if you look at the epidemiology, H5N1, most of the disease has been in children, excluding the US dairy-associated H5N1. Whereas H7N9, most of the disease has been in older adults. So the question is whether some form of imprinting or cross-immunity or something generated by the N element, the anti-neuraminidase antibodies, which are derived from egg-based vaccines, may potentially be helpful. But there are various groups looking at this, including some of my colleagues in Singapore. But I think it's a very good question, but we don't know the answer.
Well, thank you, Paul. I think we need to take a break now. We need to be back at 5 minutes past 11, but thank you, Paul. Great talk. And thank you, everyone. Thank you.